I am the main speaker today, but I'm presenting on behalf of my wonderful collaborators, Stephanie Leonard and Louisa Smith, who are also both on the call this morning. And we are here to present a short summary of some work we're getting off the ground. It is, I would say, not specific enough to get called a network study yet, but it is work we're undertaking to expand maternal and infant data from EHRs for pregnancy research. We are, Stephanie Leonard and I are at Stanford, and Louisa, as many of you know, is at the Root Institute at Northeastern. And so this is us. I'm an instructor in the School of Medicine at Stanford, as is Stephanie, but Stephanie is very soon to be changing roles to assistant professor, which is very exciting, and Louisa is assistant professor in Department of Health Sciences at Northeastern. So the motivation for the work we're undertaking is, and I guess I'll just back up to say, we've been reaching out to some people who are on this call in different formats. So this is kind of, we're spamming you in a lot of ways. And so when Craig approached Louisa with the opportunity to present at this community call, we were very excited because we're trying to really get as many people as we can involved in our efforts. So the motivation for what we are undertaking is several-fold, but primarily from a medical perspective and from a personal perspective, pregnancy is understudied despite being extremely common. Childbirth is the #1 reason for hospitalizations worldwide. There are 4 million hospitalizations for childbirth per year in the United States alone. But pregnant people are systematically excluded from most trials and studies, in spite of the fact that they are often really need effective therapies that are chosen and used in an informed way during pregnancy. And Stephanie, feel free to jump in and contribute while I'm showing these slides as well.
No, I think that's great. And then I was just showing that I think the COVID pandemic really brought this to light, given that pregnant people were excluded from almost every trial. So that's just a Lancet commentary on that. But keep going.
Right. Thanks. And at the same time that pregnancy and childbirth are some of the most common reasons and experiences that people go through in life, in the United States anyway, maternal and infant mortality rates are higher than in other similar countries in similar economic and social statuses, and increasing. And concerningly, marginalized groups are often the most affected by maternal and infant complications and death. I think it's an unfortunately well-known statistic at this point, the increased risk that Black women in specific have for experiencing pregnancy-related morbidity and mortality relative to their white counterparts. So in the US, the situation is not great. And one of the reasons for this is that there's often insufficient data available for understanding pregnancy and birth and for conducting effective studies. There are studies like the Women's Health Initiative, which was a multi-decade study that was undertaken. And so though those data are large and relatively longitudinal, it was not, the data in this study was not collected for the purposes of pregnancy and reproductive health related research. And there are other sources like NHANES that are also attempt to be very comprehensive, but rely on self-reported data and often have small sample sizes, even though it is a national survey. And then we have claims data, which we know we use very often in the OHDSI network with excellent success. But issues specific to pregnancy and birth-related research and when working with claims data are that things like vital signs and laboratory test results and condition severity are often not available. And there's also underreporting of obstetric complications. So when we rely on claims data alone, that limits the performance of statistical models that are built on those data. And then lastly, there are actually few predictive models that have been developed for use specifically in pregnant people. And some studies have found that those models which do exist, when applied in a healthcare setting for pregnant and birthing people, are often poorly calibrated and overestimate mortality risk or underestimate risks of other issues, in part because they may be built on data that is not designed and has the detail necessary for effective use in this setting. EHR data has the potential to fill some of these gaps, but they come with their own technical challenges as well. So specific to studies of pregnancy and birth, some things that are quite useful to have for EHR data are linkages between parent and child, specifically birthing parent and child. And also, dealing with missing data is a challenge when working with EHRs. But the benefits of working with EHR data in this context are that they often do provide things like laboratory test results and also information from clinical notes that can fill in some of the gaps that, as we know, are often present in claims data. And I think I'm talking to people in this community who really do this kind of work often and know the benefits that come with leveraging EHR data and also some of the challenges. So I don't need to go into this in great detail here. So with all of this context, the need for improving the data that we can have available for doing these kinds of studies, and the experience that some of us have working with EHR data at Stanford, we undertook some work in the last year with Stephanie. This was a collaboration between Stephanie and myself and other people here at Stanford to develop obstetric data extractors operating over Stanford's EHRs to do a couple of things: to identify pregnancy and birth episodes, and then also to extract information from both structured and unstructured data that captured more granular information about the birth. So things like plurality and presentation, gravidity and parity of the parent, so what the gestational age was at their delivery, how many prior children and pregnancies they've had, and so on. And we used a combination of progress notes and labor and delivery notes and flow sheets, as well as structured claims data and coded data from Stanford EHRs to do this work. And we evaluated their performance by doing a manual chart review here at Stanford. And we did pretty well for these 6 variables that we started off with. You can see that there are some that we could stand to improve in terms of precision and recall in some cases, and we have some strategies that we're going to explore for doing that work. But we're very excited by the initial success that we had in this space. And we used that data to then identify a low-risk birth cohort for epidemiological studies. And that work was also published. And the main thing that we noted here is that, Stanford is only a small number of patients and in a very specific part of the world. And so our next goal really is to try to expand this work within the US and perhaps internationally as well, within the OHDSI network. This is the prime place to do it. We think there are many of you who participate in network studies and have data about pregnancy and birth in your EHRs. And so in that spirit, we do have 2 grant proposals underway. I'm the PI on one. It's an internal Stanford proposal titled Leveraging Informatics to Study Medication Use in Pregnancy. And then Stephanie also has a proposal, K proposal underway. I'll let you describe that work, Stephanie.
Yeah, sure. Thanks, Alison. They're very related. It's focused more specifically on optimizing therapy for chronic hypertension in pregnancy. I'm sure people are well aware OHDSI has been used in the past to study chronic hypertension in non-pregnant adults. It's very different in pregnancy because there's been very controversial whether to even treat hypertension in pregnancy because of the potential risk to the fetus, both in birth defects as well as growth restriction. But a major trial came out this year showing that, kind of supporting that there should be therapy, and we think that this would be a perfect opportunity for OHDSI to really inform how that therapy should be provided and whether there's any differences for patient groups.
Great. And then with that, so this is our last slide. I think I've been talking for about 10 minutes. This is our proposal. We would, and Louisa's on the call too. If there's anything that you want to say, Louisa, feel free. But so yes, we would love to know if this sounds interesting to you, if you would be interested in contributing data to run studies along the lines that we showed as our ongoing work. If you would be interested in collaborating to develop methods to extract additional variables. I didn't go into a lot of detail there, but we are actively expanding the set of variables related to pregnancy and birth that we are extracting from clinical notes and other semi-structured forms of data in EHRs. Or if you'd be interested in proposing a project to lead a study in this space over multiple sites, we would love to be involved as well and to know what other people are up to in this space. So please get in touch with any or all of us, and we would love to hear from you. We have an email thread going out to gauge some interested parties as well, and we will be scheduling sort of a follow-up call with anyone who is interested to get more specifics. So if that sounds fun to you, please get in touch. Thank you so much for listening.
Great, Alison. Thank you so much, and thank you obviously to Stephanie and Louisa as well. There's a couple things, excuse me, a couple things in the chat you guys can look at, but we do have probably some time for questions. Anyone want to? Anyone have any questions? Please maybe use the raise your hand feature or just unmute yourself. I know Raj had.
Muted.
Oh.
I don't know if you're saying.
Yeah, sorry. Yeah,
and I can't see the
really
chat.
Great feedback in the chat.
Oh, okay,
right.
I'll find it.
Yeah. There is one specific question. So from Raj, in Alison's presentation, curious why the metrics for predicting gestation age weeks is so different from predicting gestational age days.
Yeah, that's a great question. So that is mostly about the specificity of the information. So sometimes there are, so weeks in gestational age has more opportunities to be right than the more precise gestational age of days, just because 38 weeks and 7 days is different than 38 weeks, 8 days in terms of total gestational age, but they're both 38 weeks in terms of the week granularity. And so it's somewhat an artifact of how we can measure them, but also sometimes we have to do a reconciliation of multiple data points for one person from, say, the same note or the same week. If we have two data points which say, gestational age is 38 weeks, 9 days, and one that says 38 weeks, 10 days, we have to, one will be potentially correct and one may not be. So hopefully that clarifies, but it's mostly about granularity.
I'd also just add that also just in the practice of obstetrics, the duration of pregnancy is generally measured as completed weeks. They would say 38 weeks, 39 weeks. People don't tend to say 38 weeks and 4 days, or they don't say 271 days. People don't think that. So I think there's probably differences in documentation by physicians as well. That's a great question.
And yeah, I know lots of people saying, and this is what I suspected, that there's probably sort of a silent network of work happening in this space. And it is on us that we are not aware of all of it. And so I think this is a great opportunity for you to say, hey, we are actually doing lots of work on this, and you should know about us. So that is an aim as well, is to know what is already happening in this community and to maybe bring all of us together and continue to build on the excellent work that I'm sure is currently underway.
Yeah, I just will second that. That's exactly why we're here, and we're so excited to be able to join people, and we really would like to bring this together and formalize it and lift up everybody's projects and work together. It's just kind of a general area of medicine that we care a lot about and would love to work more with other people on.